This is a big topic, but there are 4 JAK inhibitors approved for myelofibrosis in the US. For PV, just to be complete, we have Ruxolitinib approved for PV, but not the others. So in myelofibrosis, we have Ruxolitinib, Fedratinib, Pacritinib, and Momelotinib. Now, again, this is a massive topic, but I think I'll just mention a few key points. I think Ruxolitinib clearly has the longest track record and the most data. I think it is still today for most patients the drug of choice in the front line. It has the most clearly demonstrated survival benefit. That's not to say that the others couldn't or don't have it, but it's just not well shown with the others. So I think Ruxolitinib is mostly the go-to for frontline patients, and there's more and more data about intervening early with Ruxolitinib when you don't have the cytopenias, the spleen is not too huge, you don't have other mutations, the disease is sort of easier to treat, if you will, and there is data that going in early with Ruxolitinib in those populations gives you really more returns in the long run. Now, Fedratinib, I'll just quickly say that in the second line setting post Ruxolitinib in a proliferative patient, really want to emphasize that, in a proliferative patient, not a cytopenic patient, Fedratinib I think is a very good drug. Pacritinib, I use it per label. It is most useful in patients with platelets less than 50. It's uniquely suited to that population, seems to work in that population even better than in patients with higher platelets, which is interesting, but certainly fills an unmet need in that population. I will say a quick thing about Fedratinib and Pacritinib also in a little bit of a different light, that they do not, or mostly do not, inhibit JAK1, and if you spare JAK1 you cause less immunosuppression. So if you have patients that are struggling with skin cancers and infections like shingles and other things, you may want to switch to a JAK inhibitor that spares JAK1, and Pacritinib completely spares JAK1, Fedratinib mostly so. Finally, Momelotinib. Momelotinib is again a very useful addition to the arsenal, the most recent, and this drug, is its best known asset is to improve the ability to improve anemia. It's indicated in a line agnostic fashion. It's one drug that can do all 3 things: spleen, symptoms, and anemia. So it can be used in front line or second line. Most of its use is in second line, and most of the data is also in second line. However, there was a large frontline study performed, Momelotinib versus Rux, which really showed the same efficacy for spleen, not so much for symptoms, though Rux was better, but then the anemia sometimes can be an overriding factor. So really it comes down to what's the biggest need for the patient in front of you. Is it anemia, in which case you would lean towards Momelotinib, but if it is a situation where the hemoglobin's decent and you're really trying to shrink the spleen, improve the symptoms, and have that survival benefit at the back of your mind, there Ruxolitinib.